Let's get started. Digital Health Review presents stories of health equity and technology, as well as actionable advice and news at the intersection of digital health, public health, and health equity. I'm Blair Hurst, your resident Black health tech nerd and host. Our guest today is Dr. Felix Manuel Chinea, Senior Director of Health Equity and Inclusion Strategy at Doximity. Felix is a physician and strategist dedicated to driving health equity and social impact through innovation. Through his role at Doximity, he works to ensure digital health tools are designed and implemented with an equitable lens, helping the platform better serve its diverse medical network. A medical graduate of Duke University, Dr. Chinea early research on health disparities in Latina community sparked a career-long commitment to supporting marginalized communities, one he now pursues at the intersection of medicine and technology. His work has been recognized by the Aspen Institute as a 2022 Health Fellow, and he's been named to the Fierce 50 in Health Equity and Rock Health's Top 50 in Digital Health. A Puerto Rican military brat who calls Durham, North Carolina home, Dr. Chinea remains committed to the idea that innovation should make healthcare more accessible and just for everyone. You can see why we have him on here. We're going to start talking about what health equity looks like in 2026. Hi, Felix. Thanks
Hi,
for
Blair.
joining.
Thanks for having me on this episode. I'm super excited to be here. I've been a fan of the podcast for a long time. You have had some guests that I very much look up to. So thank you for having me.
Thank you for being here. I am super impressed by your bio. I am super impressed by the work that you've been doing. We have been in this field together for quite some time. I think we've sort of seen some of the cycles, and I think we are at a very interesting point right now. So I'm really, really excited about this conversation because I'm sure it's going to be really good. So, for the context of our listeners and viewers who are mostly healthcare, but maybe some folks don't know, can you tell me about Doximity and its mission as it relates to healthcare?
Yeah, so Doximity has been around for some time, since 2012. We are the largest professional network for US clinicians. We're especially built for physicians, nurse practitioners, and physicians assistants. We have more than 85% of US physicians right now on our network, more than 60% of nurse practitioners and physicians assistants. And really, our mission is to help doctors be more productive so that they can take better care of their patients. So we really sit at that unique intersection of technology and medicine, which creates this opportunity and also responsibility to better understand how our digital tools really impact healthcare. That's what's really brought us to kind of this next phase, or the last couple of years, where we've really focused on our clinical AI suite in supporting clinicians the most. And what that really is our dialer product, which is our telehealth product, Scribe, which is our medical ambient note taking product, and then Ask, which is our clinical reference tool, which is also AI powered as well. And it's not just those products individually, but it's how they kind of cross integrate with one another. So, for instance, if you want to have a telehealth call and be able to have that medical scribe activated on the telehealth call, that's possible. And if you want to use Ask and being able to make global changes to a clinical note without having to do that manually, that's possible as well. So really thinking through what clinicians' needs are from a workflow standpoint, as well as a career standpoint, and building tools that support that.
Awesome. I think, I want to like back up a little bit. All right, let's talk about Doximity's market share, right? 85% is pretty big. If you think about the type of market share you have and the availability of what that means when it comes to the type of data that you have access to, building anything in AI, I think puts you in a very unique, if not leader position, depending on how you decide to focus and deploy. So I wanted to just like make that comment, but then also back up and talk about the fact that AI is very much the healthcare play these days. Most deals, if there's no sort of AI storyline, aren't getting made. Folks who've been in healthcare for a while now are sort of rebranding or repositioning some of their products to include AI. And so there's a lot of forces that are pushing people in this direction. And like I've always said, I'm not necessarily against artificial intelligence or the use of it. I've always had a standpoint of understanding the data that's coming in, what that data set looks like, how representative that data set is to make it as equitable as possible. And early on in my career and in building some of these algorithms with teams, I definitely understood that there was a disparity. So when we're thinking about Ask and we're thinking about all the other AI tools that Doximity is now using or building, how is Doximity considering the design, right, of equitable AI and responsible clinical AI as you're deploying this out to such a large market share of healthcare providers?
Yeah, I mean, it's a super important question. And I think your lead up to that question is absolutely spot on. I think when we think about technology in general, there's always that capacity for it to have that baked in bias or perpetuating of inequities based off the design of the technology itself and where it gets its information from. The first thing when it comes to ask, I think that's really important to name is that where it gets its information from is not the vast internet. So this is not like those broader sort of AI tools that we see from these larger LLM companies that are used on a consumer basis. It's pulling information from PubMed peer reviewed articles that our clinician members are seeking to find information from anyways. And that's where they have always relied on their clinical literature and clinical reference information as well. So that's where Ask is pulling information from the get go. So I think those sorts of guardrails of being mindful of what the knowledge source is a key component and a good starting point to have from there. Now, the medical literature, let's talk about that. Medical literature has had known biases for a long time and for decades that have harmed marginalized populations for a long time. Many of us know that, whether we're talking about the EGFR equation and how there was that racial coded bias that was recently undone or recently reversed, thanks to a lot of the advocacy from physician researchers, or we're talking about the pulse oximeter and the lack of diversity in the training sets in which it was developed and that technology was designed, and the impact that that had on inequities within COVID, because it was a very relied upon technology to be able to assess patients at that time. Medical literature has had that long bias. So as we're developing, say, Ask, which is more of that clinical reference AI tool, and it's pulling from the data set, right? That's the data or the information that it's pulling from. Clinicians rightfully have hesitation around using these tools and the potential to perpetuate or scale bias from there, because these models are learning from and amplifying from that training set. So I think one thing that I'm very adamant on, both internally and elsewhere, or folks that I talk to, is just starting from the starting point of digitizing medicine without an equity lens doesn't, or without equity doesn't eliminate inequities, and it actually scales them. So we have to have an intentional equitable lens to how we design these tools before we think that these tools can really start bridging the gaps that many of us want to. So one really good example of how this comes up into play on these types of tools is I had a colleague who used Ask and was looking at psoriasis symptoms and how psoriasis presents. And it came back with the answer of, or the description of silvery erythematous plaque. And that's an accurate description for those with lighter skin tone. And it didn't go beyond that. That was the main description of how psoriasis typically presents in patients based off the question that was asked for it. Now, that same colleague then asked the question how psoriasis presents in darker skin. And it came back with a description of purple violaceous lesions. And that is also accurate for darker skin, but it was specifically had to be asked around
Prompted, yeah.
darker skin and prompted for that. And that wasn't a bug of the model, that was a reflection of how medical literature has always used lighter skin as a clinical default. So I think that's important for us to understand when designing these technologies, because if that has always been the clinical default in the training set, what does it mean for how we design these technologies to start reducing inequities and to not have these clinical defaults and maybe present an answer that is fuller and more accurate, by describing the presentation across, say, a Fitzpatrick skin tone scale or a Monk skin tone scale, and giving that full spectrum of how it presents, which is a more accurate answer at the end of the day. So when we talked about that, when we, had this come up for us and had this discussion, it really prompted us to start developing a framework that helped us navigate these situations more fully, because we could address the singular issue, but there's a multitude of ways that bias presents in the medical literature, not just in dermatology, not just for psoriasis. And so we started building out an equitable AI design framework with four goals: one, to detect; two, to report; two to measure; three, to report; and then four, to mitigate bias across the AI tool. And so when we talk about detecting, it's really about defining bias, and especially in social and clinical context, it's really about creating an internal auditing process and then understanding that lived experience matters and how that comes up with creating diverse teams across the product development pathway. And then as we're thinking about measuring, it's about prioritizing both qualitative and quantitative data. Both are incredibly important. And I worked with, some of our clinical experts and internal, folks with clinical education and experience to develop 30 plus prompts and 150 plus criteria that really encapsulated a health equity lens to start testing these models as, our teams make model fine tuning changes or model changes over time that happens pretty quickly. They could get back a quantitative score that we keep internally, and the score itself doesn't necessarily matter, but it gives a really good directional compass on, are we improving, or is it getting worse based off model changes. And so those were some really great like opportunities to be able to work with teams and develop that. And then the reporting side of things is really to capture when there is bias that comes up in outputs, which will always happen for any AI
What
tool.
do you do?
Yeah, what do you do? And so we
Yes.
want to make sure to move from observations and to make them into institutional memory that we can start learning from. And so this comes out in case reporting pathways that we developed for, employees as they're using this, and experts that are using these tools. They have a case reporting pathway to really flag and then also really describe the social and clinical bias that comes up in that output in a way that helps our engineers and developers understand why it's important and how to better understand it in a way that leads to engineering input and changes to the actual tool itself. And then it has also allowed us to really lean into Peer Check, which is a program that we have within Ask that brings in clinical experts on any given clinical topic, and they actually review the answers on
Mm.
somebody ask. And because we have that network and we have their profiles and we understand what is their clinical expertise and background, we can put their profiles or their picture and profile and their background attached to that approval of, this answer is correct to this clinical question. And here is their background that kind of gives them more credibility on why, you should trust the answer to this and trust that this expert approved that answer. So peer check exists outside of this equitable AI design framework, but how we lean into it is recognizing that we're doing this across all these clinical expertise verticals, but health equity is a horizontal across all those verticals. So we want to ensure that we're recruiting experts to answer those questions of whether those answers are correct or not. And we want to make sure that we're recruiting experts in those clinical topics that also have a health equity expertise as well, because that is a unique position and unique expertise in general. And then lastly, this ultimately is meant to mitigate bias, right? So like we collect all this information, we detect it, we're measuring how we're doing and reporting. Ultimately, we want to close the loop on this. And so we need to ensure that we understand that not all bias has the same solution. So that taking in that social clinical context from the reporting side of things, we need to take that into what leads into the type of fix that we have as well. So my team really collaborates with technical teams on that, and then making sure that we're just moving from intention to like infrastructure and that engineering input of things. And so ultimately what I oftentimes tell teams is health equity and clinical quality are the same pursuit. Like they're the same thing. What we're doing here is centering marginalized communities and centering equitable design of the product, but it ultimately just leads to better products and better experiences for everyone and more accurate answers for our clinician members. So, yeah, it's been
Yeah.
exciting work.
I wanna first of all, let's give you kudos to that because I think that is probably farther than most organizations go, okay? I myself have worked in organizations where this type of work was deprioritized, and I think when you work in a lot of, early stage development or early product development and startups, sometimes speed or the request for speed, gets pushed rather than these initiatives, and so I the first follow-up that I have to that is, how do you balance maybe outside forces wanting features, etcetera, to be pushed out, knowing that this type of work, building frameworks, building in feedback loops, mitigation, internal education around why we're even doing this. These things take time. And because your program is so expansive, how do you manage not going a mile deep, but only going an inch far out, right? Because you are building the verticals, but you're also building horizontally. These are sort of the struggles that I've seen in organizations when trying to balance product and AI development with health equity measures. And then the last thing that I wanted to say, which is the program is extremely expansive. One of the things that I think is sort of also underutilized, and maybe you can speak to this, is the education piece, the health literacy piece back to the providers. How are you, or how can folks present these AI solutions not as the end all be all, but saying, hey, you're looking up this rash and what it may present. Okay. Have you considered these pieces of information or data around your case or around your patient? When you looked at their response, did you understand that this is a supplementary response? You still need to go through an evaluation. Do you want to reach out to an expert that we can use using your peer network, right? I think sometimes we very much hone in on, and I agree with it, the antitrust of consumers or patients on healthcare, and you touched on this as well. There's also an antitrust on with physicians when it comes to AI. I remember back in the day, I used to implement solutions that used RFID, right? So this
Mhm.
was like real time tracking patients, and we were working on a lot of initiatives around this, right? Exposure risk, fall risk, noise. There was a lot of use cases when it came to the providers using this tool. Sometimes they didn't want to. Sometimes it ended up in a laundry bin or a trash can, right? There is very much a need to provide training and education and adoption on the provider side. So with this like advent of AI and sort of its onslaught to providers who I would assume have rightful sort of I don't want to say necessarily apprehension. Well, I'll say it, apprehension about these things. How is Doximity thinking about that? How are you thinking about educating providers around what these tools are, what the outputs are, what the outputs are made out of, and what do they actually have as far as support and understanding it and using it.
Yeah, no, all of those are great questions. I think to tackle the first one, around how do we prioritize these frameworks like in a fast paced kind of development environment where,
And knowing that there's multiple organizations, I'm a
yeah,
part of a coalition of AI. There's so many organizations that are creating these AI frameworks, and which is part of the issue in healthcare. Everyone has their own fire, the whole fire debate as well. Every FHIR for those folks that are just listening. The fire debate, right? There's so many different types of systems and frameworks that it can cause an issue when you're thinking about interconnectedness and scale, right? So
yeah.
add that to it.
Yeah, absolutely. And I think the other complicating factor with these frameworks that like I'll add into that is that when we say AI tools, there's a multitude of ways that that can present in the product itself and the design itself. Are we talking about Scribe tools? Are we talking about clinical reference? Are we talking about like AI as kind of like sitting in the background behind a dashboard? Like what are we talking about specifically when we're talking about the design of these tools? And they look very different. And that's where I think for folks in roles like mine or trying to make impact in within organizations in the way that I'm trying to make this impact, I think it's really important to understand the business of the organization, understanding the products really well and how the teams work. One thing that a quote that always rings true in my head from a past podcast episode that I listened to years back was doing this work in a way that's hard to unwind. And that always repeats for me. And I think that is the way to balance the speed and the urgency of doing this work in ways that are slow and really integrated. Because what it forces you to do is to understand how teams work, how they're incentivized, and what is the like the highest priority for them, and what type of feedback gets them to shift and change directions or change or shift decisions. And so you can utilize that, right? When we talk about Doximity, so much of what we do is designing with physicians in mind. So physician feedback is really important to us. Hearing from them that they're concerned around bias is critical for us to hear and for us to better understand. Understanding their clinical context and seeing a patient with psoriasis, for example, and wanting to ask that clinical question and needing an accurate answer without assuming what their patient is presenting with, because that actually creates more time for them to have to ask that follow-up question to say, like, no, actually, my patient has darker skin tone. How would it present in this? We're here to save them time. So we don't, those assumptions lose time for those clinicians, and it creates a cognitive load that we don't want to put onto them. That's just a poor product design. So we want to address that. And so really leaning into that understanding is really critical from our point of view. And so being able, I think setting these foundations and leaning into the speed of developing features can happen at the same time. We don't have to slow down teams to do that. We can have them continuing developing features while we start integrating in scoring or internal benchmarking or feedback pathways that help give them a sense of like, okay, we need to move in this direction, or these are the types of things we need to fix and prioritize. I've been lucky to be able to work with product teams that really embrace that.
That's amazing. That's
Yeah.
amazing. I think you guys are on the right pathway. I think that also speaks to the users of Doximity around what type of product they're using and knowing that it is, committing several resources and time to making sure that the AI implementation that they're doing is doing the best it can to get it right. So, these are the types of use cases that I think don't get talked about enough, particularly because a lot of folks are just now developing it, but also keeping a lot of information in house for a variety of reasons. What I personally have been moving towards is not just understanding, right, like equitable healthcare in a healthcare setting, but the things that help grow these types of businesses and products. And that has directly led me to sort of a deep dive and work in the capital infrastructure. I know from our conversation and research that Doximity has a sister arm called doximity.org that has started a lot of social impact work. I'd love for you to give me a quick overview of what that has been and what it could potentially build in.
Yeah. No, we're very excited of having launched doximity.org last fall. It's really kind of a continuation of the story of a lot of different initiatives that Doximity has long had and really kind of bringing them together into a singular social impact arm. But I think the way to understand it, the easiest way to understand it is really rooted in our core business mission, being physician first and understanding that, that extends beyond the products that we build and how we're trying to better understand the environment in which physicians are practicing in and what healthcare is in right now. For example, physicians, are suffering symptoms of burnout. We see 45% of physicians report at least a single symptom of burnout. And I think it was in 2023. There's the physician shortage. We're going to
There's
have
a
a
high
shortage.
physician PCP suicide rate as well.
Absolutely. So physician shortage as well, 124,000 doctors that will be missing by 2034. Like you mentioned about, physician suicide rate for women physicians, they actually die by suicide at twice the rate of the general population. And then we also see that over 50% of physicians are stressed by their patients' social determinants of health needs. So not only are they kind of having this moral injury and struggle in their own professional life, but they're also having this moral injury around meeting the needs of their patients and the communities that they want to serve. that brought them to the profession in the first place. And so as we move our mission forward and develop these digital products, obviously these digital products aren't always able to address all of those needs, even as we're, reducing administrative burden and reducing cognitive load for physicians through some of our tools. There was an opportunity to work in that more social impact lens and developed a more social impact mission that could help partner with organizations or allow us to function in a different way. So this comes up in 5 initiatives that are within Doximity.org and is really fueled by volunteerism, innovation, and funding. So it's really how we donate our people, products, and profit in the way that we work. And so it centers on this belief or our mission that clinician well-being and the health of underserved communities ultimately leads to better outcomes for patients by improving those things. And so those 5 initiatives are Doximity Foundation. Doximity Foundation is a separate 501(c)(3) that offers airfare travel grants to clinicians going on global health trips. We've been able to work with a number of global health organizations through Doximity Foundation. And since its inception in 2018, it's been able to give 1.8 million in airfare travel grants and supported travel to over 50 countries. The next one is Doximity for Free Clinics. This started off as Dialer for Free Clinics. So it was us giving our telehealth product to free clinics at zero cost. But since last year, it's expanded to giving enterprise level access to Dialer, Scribe, and Ask. So in addition to telehealth, also our AI powered tools as well at zero costs to free clinics. And we work with about 150 free clinics at the current moment that we've been working with for years since 2021. The next one is the Physicians Executive Program. This is a newer one where we partner with Stanford and support educational pathways for physicians that are looking to become hospital CEOs or hospital executive leaders because of it's rooted in our understanding that only 5% of current hospital CEOs are actually physicians, and that can actually lead to better hospital outcomes and better morale for their staff as well. The next one is Docs Gives. This is our way our employees kind of led movement around volunteering within their local communities. We have over 1,000 employee volunteer hours that we've accumulated over the years. And this year, we actually started, for the first time ever, a committee that's able to support all the different employees all across the nation that we have, because we have about 90% of our employees that are remote. So we're all across the US. And so that committee really supports scaling this work in a way that folks feel good about it. And then the last one is Doximity Impact, which is just reflective of how we opportunities we can use our profit and partner with other nonprofits that are mission aligned with us in a more flexible way. But as you can see, kind of from these 5 different initiatives, ultimately the tools that we're using is really like product grants, grant funding, and strategic partnerships in ways to kind of help address the needs that our clinician members have and really get at that clinician well-being and the health of underserved communities.
I really like how you're using grants to support this work. You know, you have your sort of business in Doximity and your philanthropy work in Doximity.org through these initiatives. And it seems like you really are trying to, obviously, of course, educate, but also implement in a way that sort of releases that burden. I was unaware that the free clinic was giving enterprise level access to these tools, which is kind of really unheard of, especially because I work with a lot of providerpreneurs, right? So providers that are exiting outside of maybe larger hospital networks that are trying to create some level of change in their local communities. But obviously, as you know, there's going to be a gap between the level of resources that you may have at a hospital versus a clinic or a practice that you're starting
Absolutely.
on your own, and the cost of those things can be quite high. So this is a very good resource. I'm definitely going to have to do some research post this call about that. You know, a lot of what I've also learned when it comes to some of this nonprofit work is that it's heavily used in rural settings, right? So there's a social impact sort of spike that I'm in, and as well as the rural healthcare that I'm focusing in on right now. How do you imagine, like, Doximity.org using its ability to have all of these, nonprofits and initiatives support places like, you know, rural America or other rural places that could benefit but may not have the infrastructure like Doximity to apply, get all those grants, et cetera?
Yeah, no, it's a really great question. I think when we think about rural healthcare, the first thing that comes to mind is like the compounding crises for them around shortages of clinicians, having a clinician shortage, the geographic isolation, and then having those limited resources, like you mentioned. In addition to that, I think we think about the current moment of Medicaid rollbacks and how what that means in terms of more uninsured patients really turning to not just FQHCs and community health centers, but especially free clinics, especially those who are uninsured are turning to those and really turns them to become that safety net below the safety net
Yes.
for healthcare and for patients across America. I just want to emphasize that first because free clinics are doing incredible work with very limited resources and are really showing up for communities, especially in rural areas as well. That's where we see some of the most amount of free clinics popping up and have long been in those areas. I think juxtaposing that with the fact that we know billions of dollars have been flowing into health AI is really interesting because we also know that it's not oftentimes toward those who most need it, who need it most. That's where I think Doximity for free clinics really comes into play and the importance of this program to not only serve free clinics and really support the work that they're doing, but also benefit us. Because oftentimes, one of the first questions that we're asked is, wow, you're giving away your product for free to free clinics. What do you get out of it? There's hesitation around that. And rightfully so. Folks are curious about that, or will it disappear? And like, what is the incentive?
Yes.
Is it sustainable incentive to be able
Can
to,
we rely on this?
can we rely on this, right? Is this a 2-year thing or a 1-year thing that's going to disappear? You're going to ask us to pay for later. And super valid question. Full stop. Like, we're not asking them to ever pay us and we're not planning for this to ever disappear. The way it benefits us is how I think about it is the curb cut effect is really, and this same thing applies to the equitable AI design framework where designing for those on the margins or designing for those with little resources who are practicing in those clinical settings gives us feedback that we wouldn't get otherwise on those products. And it creates that feedback pathway and it helps us develop just better products in general. So as we're thinking about giving these enterprise grade tools and development of those tools, we bake in the safety net perspective into that by having those communication pathways and those relationships with free clinics. So we're offering Scribe, Dialer, and Ask. So Scribe helps support their chart ready notes, less charting, ideally less burnout for
Yeah,
those.
give a description. I don't think you gave a description. I know what Scribe is. I've helped people implement Scribe, but
Yeah.
I don't think you gave a description of what each product does well.
Yeah. So Scribe is really that ambient note taking tool that is listening in on the clinical conversation and being able to output a ready templated note based off the template that you select or that you design. It can be different templates that are customized to your needs, your specialty practice, or like your specific needs and preferences. And so, as you're having that clinical conversation and you can focus on the patient, you can have that chart ready note at the end of that conversation without you having to look at a computer the entire time and type on a keyboard. The other tool that's offered, obviously, is Dialer. So, that offers voice only, video, and text, all HIPAA compliant telehealth offerings, as well as it supports up to 6 languages on Dialer as well, which is very important for free clinics. And I'll touch more on that in a bit because free clinics actually helped us develop that feature. And then Ask is that clinical reference AI tool where it's kind of like that typical chatbot that you understand from other consumer AI tools that's pulling information from peer reviewed literature. It gives you answers that are bottom line upfront clinical answers, but gives you a fuller understanding of where that answer is coming from. It's riddled with citations that are hyperlinked that you can go directly to the article to really ensure, okay, I asked this question, I'm getting this answer. How can I ensure that is actually coming from this article? You can verify that. And then we also offer understanding that Those in rural healthcare settings, especially, aren't always attached to an academic medical institution, may not have access to full text journal articles. Doximity Ask offers up to 5 full text articles, PDF articles per month per user. So this means that when they click on that citation and they see that article, it will say free full text provided by Doximity. They can click there and go to the full text, and they have up to 5 of those articles per month. It also does prior authorization forms, so a lot of administrative tasks that you can imagine. So moving from like a Scribe note and saying like, take this note and write a prior authorization form for this patient, it can do that. It links up with our eFax tool, so they can then fax it to the health insurance company. So all within the Doximity suite, all this is offered to free clinics. So as you can imagine, when you're really strapped on resources, this can be a huge time saver when you're trying to use the most amount of time and bandwidth that you have from clinician volunteers, because they're oftentimes relying on volunteers. And so over the years, we've been able to, reflecting back on last year in 2025, we had about 29,000 voice calls, over 2,000 video visits, and over 6,000 secure text from free clinics alone. And like I mentioned before, we're working with 150 plus free clinics over the years. And what we're really aiming to do is the same mission for all of them, which is just really improving access for them through either through telehealth or through the texting feature that can really help them follow up with patients and improve patients coming back, and being responsive, increasing the flexibility for their volunteer clinicians, and really helping them with that burden of administrative burden that they oftentimes don't have a ton of resources to be able to address. I mentioned the language part, right?
Yeah.
That sort of language expansion feature is really useful for free clinic. And I think there's an interesting story about that. So one, when we first started this program, we had a free clinic that told us, hey, we're using this product a lot. The way Dialer works is really a clinician goes on the Doximity app, types in the patient phone number, it sends the patient a text saying, Dr. So and so would like to start a telehealth visit with you. Here's a hyperlink. They click the hyperlink. It presents them a short consent that they can consent for the call, and it opens up like a FaceTime call. So design wise, it's a one tap into telehealth. It's insurance agnostic, very simply designed for if we're thinking about digital literacy perspective. Now, that text would be very useful to end up in the language that the patient uses and that the patient prefers, right?
Right.
Because they're reading that. So that was the feedback that we got, that we have a lot of patients who don't speak English. I think this particular clinic, it was mostly Spanish speaking patients. It would be really nice if we had a feature that accounted for that. And so our engineers, over the course of a few weeks, designed a feature that was able to read the default language on the patient phone, because patients never go on our app. We don't have patient data. We don't want them to be on the app. We want to maintain HIPAA compliance. And there's really not a need. We just need them to enter the telehealth call. That's all they're looking to do. And so it reads the default language on the patient's phone and is able to present that text in that default language seamlessly without the provider or the clinician having to actually select the language either. And fast forward a couple years later, we actually ended up getting really positive feedback from an enterprise client that practiced in New York City that had a lot of patients that spoke of various languages. And so it was a really great example of how designing product features for those who are practicing in those low resource settings actually just develops a better product that
Amen.
it's
Amen.
ever.
It's like, I studied engineering. It is sometimes that fact that constraints sometimes breed the best solutions. And that's exactly it. I've seen the process of trying to connect a physician on one end to a patient that speaks another language using a third party translating service, hoping everyone has stable internet and is at the right time. And it's quite cumbersome. So the one click, one step is truly amazing. And what I like about all these things too is that in some ways they're lightweight enough to be used in a variety of fashions, especially in rural settings where people oftentimes have to think on the spot, re-engineer workflows. Like they're really built to embed in multiple different types of workflows, right? I need to send a text here. I need to be able to, use Ask there. This is how we're gonna build up the workflow, and we can use it all under one ecosystem, which I think is really nice, and then the free clinic support is also extremely really nice. I'm gonna ask you and push to see if your product team has thought about supporting these features without Wi-Fi or without internet access. It's a huge thing in, rural communities. Our call could drop in any second now. I live in a rural community. We never truly know, but thinking about Doximity, it's like flexibility, it's great use in communities, either free clinics, community health workers, right? These organizations that are doing this stuff, driving from their clinic site to a patient's home, maybe missing internet, or a signal. How do these things stand up for the actual, you know, live use inside of a rural setting? Do they work in that
Yeah.
way?
Yeah, they absolutely do. That was one of the first perspectives or design sort of thinking that we had with Dialer. So like Dialer has always been designed with flexibility in mind. And I think that's the part where it's really critical. Like, can it work off of, cellular data signal? Of course it can. It also has the flexibility of switching from a video telehealth call to an audio only. So if
Mm,
folks are moving or if their signal or access changes in the moment, you can switch to an audio only call as well. I think that flexibility is really critical in design of these telehealth products because you don't one like you don't the current status or the current setting or like reality for a given patient is not the same for the next patient. But as you mentioned, patients may be moving. We know that signal hops in and out, even if you're not moving anywhere. Sometimes that changes in the moment, like different changes happen. And so
yeah,
building for that sort of flexibility of being able to keep the call, keep communication in critical conversations, like clinical conversations with patients is super important. So I think that understanding of like the audio and voice or video and voice switching is really critical to that. And we designed the product also to be able to support even video calls in low signal settings as well.
that's amazing. That's amazing. I mean, thinking about this conversation today, I think there are so many lessons that can be learned by other organizations and how you decided to build out responsible clinical AI, how you are building out the feedback loops, how are you supporting it with Doximity.org for the community building, on the ground support. You're using your access and resources to uplift the communities that aren't necessarily getting it. And by that, by the way, I am definitely going to follow up with you on this because there are folks here in the Catskill regions that are already building out their community health organizations and these clinics to support, not knowing that Doximity exists, not knowing that the Fleet Clinic program is even a thing, right? And so I think there's still opportunities probably for that level of growth. I've learned an incredible amount from you. I can definitely tell that you have patience, especially in how you're building and understanding how teams make decisions and are incentivized and building out sort of these equitable practices over time. And so I want to give you kudos on that. Definitely
Thank
weak
you.
spot on my part for sure, but I think that's probably why Doximity has grown so well because they have leaders like you at their helm, pushing them and also getting the word out about what you're doing, which I don't think you do enough of, which we've talked about already. But I really appreciate you being on the podcast. I really appreciate you sharing your expertise. I'm going to continue to watch you, your career in Doximity grow, and we will definitely be connecting after this. Appreciate
Yeah.
you.
Thank you so much. And I appreciate the time on this call and I appreciate the conversation. We both agree that, this work needs to be talked about more. I'm grateful to collaborate with some really great colleagues and leaders like within Doximity supporting this work. So thank you for uplifting that.
All right, Felix.
All right.
Thank you for joining us. If you'd like to subscribe to our newsletter or listen to more episodes, please go to www.digitalhealthreview.com.